Welcome everybody. Good afternoon. Welcome to Global Response to COVID-19. This is webinar section number 13. This meeting is sponsored by the Panamerican Trauma Society, American Association for Surgical Trauma, International Relations Committee, World Coalition for Trauma Care, and supported by University of Miami and Virginia Commonwealth University, VCU. Today's conference is going to focus on the ICU care of these critical COVID-19 patients. We're going to have reports from South America and from North America. And the idea to use the expertise of the panelists and the presenters to discuss the management of these patients. You may have the feeling that you are winning the COVID-19, but this week you have the greatest number, the biggest number of new cases ever. So the COVID-19 is still growing fast. Unfortunately, now in South America, it looks like and Latin America is the epicenter of the disease. So we're going to have multiple discussions. We still need to keep helping the countries in Latin America to discuss the management and to manage the situation. So I'd like to ask Dr. Michael Butanos from VCU to introduce the panelists from today. Thank you.
There we go. Great, thank you. So again, it is really our pleasure to introduce all the panelists, and as Dr. Antonio Martos have, the surge is in different aspects, and some cases may already be on their way down in some continents and other continents, especially in Latin American region. It is very much still on the rise. So this has been an ongoing session. So it's my pleasure to introduce all the colleagues, friends, experts in this field. So I'll start with Dr. Ricardo Lima, Professor of Surgery at Federal University of State of Rio de Janeiro and Head of ICU at Samaritano Hospital Rio in Brazil. Dr. Sandro Rizzoli, Medical Director of Trauma at Hamad Hospital, Editor-in-Chief of the Panamerican Journal of Trauma, and co-editor of GEMTAC, and he hailed for us from Qatar. Dr. Marta Chiodetis, Head of Trauma Unit at Hospital Santo Tomas in Panama. Dr. Esteban Guainini, Panamerican Trauma Society Treasurer, Director of ATLS in Bolivia, Surgeon General Director at the Fuenini Hospital in Santa Cruz de la Sierra in Bolivia. Dr. Napoleon Mendez, Professor at the University of San Carlos and Chief of Surgery of the Emergency Department, Hospital San Juan de Dios in Guatemala. Dr. Rafael Barrera, Director of Surgical Intensive Care Unit at Northwell Health, Long Island Jewish Medical Center in New York, in the US. Dr. Felipe Vega, President of the Pan-American Trauma Society and trauma surgeon, Department of Surgery, Hospital Angeles Lomas in Mexico City, Mexico. And Dr. Thomas Calea, PTS Executive Director, Professor of Surgery, University of Maryland School of Medicine, and Physician-in-Chief of the R. Adam Cowley Shock Trauma Center in Maryland, United States. So those are the list of the panelists. Welcome. And I'll turn it back to you, Antonio.
Yeah, so we're going to have 4 presentations today. The first presenter, Dr. Jorge Neira, a great friend, very active with the Panamerican Trauma Society. He's the president of Fundación Trauma in Argentina. He's an intensivist ICU consultant at Sanatorio de la Trinidad, Palermo, and president of the Certification Council of the Med Specialties and former president of Panamerican Trauma Society. He's from Buenos Aires, Argentina. We have also Dr. Thais Tapajos, a young surgeon. She's an ATLS instructor, a professor of surgery at CESUPA, general surgery residence co-director at the Hospital Universitario João de Barros Barreto, general surgery resident and director at the Urgência Emergency Metropolitan Hospital in Belem, Brazil. Belem, Brazil is a huge center of COVID-19 right now. We have also Dr. Kristin Miller, Associate Director of and Medical Respiratory ICU at the VCUHealth, Associate Professor at the Department of Internal Medicine, Division of Pulmonary and Critical Care Medicine at the Virginia Commonwealth University, Richmond, Virginia, USA. Also, Dr. Marjolaine DeWitt, Professor of Medicine at the Department of Internal Medicine and Division of Pulmonary Disease and Critical Care Medicine at the Virginia Commonwealth University, Richmond, USA. We're going to have these 4 presentations, 10 minutes each, and then we're going to have the pool of questions and then discussions. I'd like to ask Dr. Michael Butanos to welcome all the associate societies that joined these meetings for 13 sessions. Michael.
Yes, thank you. If I can show all our affiliated societies, we're incredibly thankful for all the participation. We have more than 50 trauma and emergency, general surgery and acute care surgery, and intensive care societies joining us. So we welcome all their support and the promotion of this very, very important webinar that we've been having. So welcome everyone and all your representatives. Back to you, Antonio.
Thank you very much, Michael. So I'm going to start with the presentations. Please keep an eye on the time. So we need 10 minutes each. We'll start Dr. Jorge Neira from Argentina. Dr. Neira, welcome. Thank you for joining us today.
Good afternoon, everyone. Thank you for the invitation to participate in this important meeting. It's a pleasure to me to show you our experience in the COVID-19 pandemic and the current situation in Argentina. This is our country. As you can see, our country is divided in 24 states are called provinces. One of the states is the capital city, as I'm going to show you later. And you see the continental sea and the Antarctica that belongs to our country. In the islands, you see Malvinas, Argentinas, and also the southern Sandwich, Georgias, and Orkneys Island. Our population is about 45 million inhabitants. Excuse me. And our life expectancy is 73.8 years. As you see, in the last 70 years was increasing. And you can see later here lower the GDP in US dollars, how is changing, and this is related to the usual economic crisis that we have in our country. As I come on, the capital cities here, and the surroundings of the province of Buenos Aires. This is the capital city called Buenos Aires and the province of Buenos Aires. You see here the capital city and the surrounding neighborhoods that are called the Metropolitan area of Buenos Aires. This metropolitan area has about 15 million people. It's 1/3 of the population of the country is here in this metropolitan area. And this is the capital city. The capital city has 3 million people in 200 kilometers square. The surface of this metropolitan area is 3,680 kilometers square. It's 18 times larger than the city. This is our health system. We have a very particular health system. And you can see here, 70% of the population of the country has Social Security and Medicaid, Medicare. And this is the public sector. The public sector is for 30% of the people that have no any kind of coverage. But the interesting thing is any person in Argentina can be attended in the public hospital for free. Even the people, the visitors of our country can be attended for free in the general hospital. We have a general coverage, but the equity is different if you compare the public with the private or the social security system. Some numbers, Esteban showed us some numbers last week. The only want to show you is that in terms of the per capita, the expenditure per capita is about $2,000 for each inhabitant. And the amount of beds all over the country in hospital beds is 50 per 10,000 inhabitants. Here you have all the infrastructure, current infrastructure. We have about, as I mentioned, almost 50 beds for every 10,000. But from these are general plus rehab. Only general is about 27.7, it's 125,000. And in terms of intensive care, we have 11,000 beds for intensive care of the adults, 1,800 for the pediatric, 5,000 for step-down ICU. The numbers of ICU are 950. The numbers of ventilators is about 70% of the ICU beds is 7,800. The number of intensivists is 1,300. And in Buenos Aires city, we have 1,000 beds. It's interesting to see this. And all over the metropolitan area is 4,073 beds. This is important for our comments later. The Army and the Air Force deployed hospitals. This is the deployed hospital of the Army, and this is for the Air Force. We also make some infrastructure in stadiums, as you see. This is for mild patients with feverish patient that has to be diagnosed of COVID. It comes from these facilities distributed all over the country, and also with some tents with different facilities all over the country. This is our reality. This is from yesterday. Yesterday, 5:59 in the evening. We had about 24,748 patients and 717 dead people. Excuse me. And important is this is we started the first case in March the 3rd, and we started the quarantine in March the 20th. We now are an 82-day of quarantine of the lockdown. As you can see here, the proportion of people regarding sex is half and half. And here is mortality. Mortality is, of course, related to age, and the proportion of males and females are almost similar. This is supposed to be a joke. It's not only will a poor man have more chance for entering the kingdom of heaven, he'll also get there sooner. And it's the cruel, the harsh reality in Latin America. If you see in Argentina, there is about 4,100 poor settlements, slums, or villas miserias, as we call, or favelas, as is called in Brazil, or barrios callampa in Chile. And in these settlements, only 3%, this is fortunately 3%, the people are older than 65 years, and this is related to lethality, as we can go to show you. This is some of them very close to the city here, and these are the old settlements around the city. This is the metropolitan area. For that reason, the provincia of Buenos Aires are here geo-reference the cases just for make a follow-up of the contagions. This is for the city. The city has about 12,000 patients. The city and the metropolitan area has about 80% of the cases of the entire country. The lethality in the city is 228, of the nation is 3.8. And interesting, in the poor neighborhood, the lethality is 0.97, and this is related because to the young age of the people living in the poor settlements. This is a comparison with Latin America. Here you have the confirmed cases, confirmed death per million people. You see the United States first, Canada, Ecuador, Brazil, Peru, Chile, Bolivia, Colombia, Argentina, Uruguay, Paraguay, and Venezuela. And this is the amount of cases per million people. You see also Chile was increasing in the middle of May. It's interesting because this is related to the daily test and confirmed cases, and it's irregular. I was thinking of the comments of Raúl Coimbra last week, that he said that probably mortality and lethality was related to the amount of tests. I am not so sure, because, for instance, the mortality in Argentina is 3.8, and the amount of days is lesser than Chile, that has a mortality of 1.8. But the United States has a mortality more than 6% with more amount of tests. And this is the same. This is mortality rate due to coronavirus. The first one is Ecuador, and here is the test performance. And you see how Peru is the first country in terms of mortality, and Ecuador is here. Excuse me. Ecuador is here. And other countries, for instance, for Argentina, when you see the relationship between daily tests and new confirmed cases is variable. It's really variable. Here is Argentina, here is Paraguay. Paraguay has lesser mortality than us. And here you see the confirmed cases and the number of tests. And also you can see here Australia, and here Costa Rica is on United Kingdom. United Kingdom has a high mortality with low tests, and there is no a linear relationship between mortality and amount of tests. I think this is a paper that we can present at the Panamerican trauma, comparing all mortality and fatality rates and test and economic impact. I think this is important. Here is the same. You can see the mortality rate of different countries. The first is the United States. And you see here, Argentina is 14.4, Uruguay 7.7, Paraguay 1.6, and Venezuela is 0.76. And the other countries, the second is Ecuador, and the third is Brazil. And this is our confirmed cases all over the country. As you see, some parts of the country is free of virus, but probably the most important amount of cases, as I say, more than 80% of the cases are in the metropolitan area, and this increased from the May 21 to June the 3rd. Now we have the 272 patients in the ICU, and the occupation rate is 35 to 38%. This is very important. The lockdown was extended until June 28 because you have two types of quarantine. One is related to the metropolitan area, one is related to the other part of the country. And if you see here, this is the duplication rate of cases, and the total for the country without the metropolitan area is 43.8, but if we add the metropolitan area is 15.5, because metropolitan area has a duplication rate about of 10 days. This is the reason, because the lockdown was prolonged to June 28 in the metropolitan area, but not in the rest of the country. And this is very important because it's the impact of the lockdown on mortality if in Europe, and you see if the estimated number of saved deaths in Europe due to the quarantine. The only problem is that the economical impact is very, very high. In our countries, less than 6 points of the gross domestic product. This is very, very hard to deal with in the post-pandemic period. As you know very well, this is the graphic of treatment. This is our protocol. We can discuss later. This is what we use, and we can share some experience with the other colleagues. This is a solidarity study. Solidarity study is a World Health Organization protocol that was implemented in Argentina also, where Argentina was invited to participate. It has 5 arms. One is usual standard care. The second arm is remdesivir. The third is lopinavir-ritonavir. The fourth is lopinavir-ritonavir plus interferon beta. And the 5th arm is hydroxychloroquine. This is ongoing trial. We have some information in the next weeks. And for finishing my presentation, in Fundación Trauma, we prepare a training course for increased search capacity of health team workers. Our idea is to train 5,000 non-intensivist team workers around the country. But this is supported this course is supported by the National Society of Intensive Care and the National Academy of Medicine. The motivation is to design in virtual training on critical care and surge capacity, preparedness in health facilities for strengthening health facilities and health teams and local health authorities. And the objective is the preparedness of non-intensivist professionals, physicians, nurses, and physiotherapists to share COVID-19 critical care patients with intensivist professionals, along with infrastructure investment that was already done in our country. This is our situation, and I am going to answer the question that you have. Thank you very much for my invitation.
Thank you very much, Dr. Neira. A great presentation. We're going to have good discussions afterwards. Let's go now to Dr. Thais Tapajos from Pará, Brazil, from SBITE, Brazilian Trauma Society, to talk about what's happening in Pará and how the state of Pará is dealing with the COVID-19 surge. Thank you, Thais.
Thank you, Dr. Martos. And first of all, I'd like to thank you for the invitation. It's a very pleasure to me being here today representing our Trauma Society SBITE, talk a little bit what happened to us during these days. So I'm going to share my presentation. Is that okay with my sound?
Yes, ma'am, you're good.
Thank you. So let me start here. Just a second. Okay. And first, I'd like to introduce myself. My name is Thais. I'm a surgeon, general surgeon, and gastrointestinal surgeon. And today I'm representing our trauma society in Brazil, SBITE. And I'm representing 2 hospitals where I work. So those are the hospitals. First one is the Federal Hospital, Joao de Barros Barreto. And there we have a surgery team. We have a program of surgery to general surgery and GI surgery. And the other one is our trauma center. Metropolitan is our the only one trauma center here in Belem. So, what was the most concerning thing about everything was happening in the world is thinking about our place, our state. We have too much different scenarios in the same state. We have the capital and we have the other cities. We have the river sides. So this pandemic for us was a thing that we had too much concern about. For example, in this picture, we can see a reality. This man's a doctor. He is going to see some patients, riverside patients. And that's seeing that picture, we used to think, and what coming next with this pandemic? So this is our state. We have the second largest state in the Amazon. The first one is Amazonas. And we have a large population. We have 144 cities, and Belem is the capital. And we have a little bit more than 1,040,000 inhabitants. So, and our hospital reality always was difficult when we see the public side of it. And the private ones, it was okay. But our reality is in capital or even in 1 or 2 or 5 cities, we have private hospitals, but most are public ones. And we have even municipal hospitals and state hospitals. And beginning in the pandemic part of it, we have 654 ICU beds, and most of them are here in the metropolitan city part of the city. And the 1,429 beds are clinical. So it's the major, but wasn't our problem. So to understand what happened to us, I built a timeline where we can see our progression. We begin with the first case in December 1st in 2019 in Wuhan. Then we got our first case in Brazil. It was on February 26th, and it was on São Paulo. In March 16th, our trauma society began with some meetings for focus on COVID problems. And my interest on that was getting some help or learning about what happening in the other part of country, because in this time, we didn't have any case at all. Our first case came on March 18th, was a man, 37 years old. It was confirmed on Belem, and he went in Rio de Janeiro for Carnival. And the most interesting part of it was that this man went 5 times trying to get some help in different ERs in Belem. And just in the last one, he got the possibility of diagnosis of COVID-19. So he walked around the city for a long time since COVID came in mind. So, and in April 2nd, we had our first death in our city. And we had at that time 48 cases. Then in April 7th, our government became with restrictive measures. Just some part of commerce can function normally, but for our society, that is not that easy to go there and come true, actually. But we have a little bit more than 100 cases and just 4 deaths. In April, we already had another one, our first actually, field hospital. What was the problem of this hospital? It was 400 beds, but just clinical beds. And our problem was the ICU beds. And unfortunately, in April 18th, we crashed. We had in this time more cases. We have 1,600 cases and 33 deaths. But this date was when we start a nightmare, because we saw things that I can't even imagine that I would see this one day, or even my colleagues. So those are some pictures of this time. Here we have 3 photos. Those are private hospital full of people trying to get some help. In this image with these cars, and those cars was in front of a pharmacy, and this truck was bringing chloroquine and hydroxychloroquine from the city. And when people knew that, they just ran to the pharmacy, and those were very common images in this time. More pictures. Those those just above here. And this one is from a municipal ER we have here. We had we heard some histories from our colleagues, things like we had more than 30 deaths in a night shift. So it was very impressive. We had lots of bodies in the hospitals or even in the necrotary. So it was very nightmaring. More pictures. And so we can see there, just here below, a great hospital from the state. And I'll show you a little video.
Arrebentando o portão do hospital. Olha o desespero, meu Deus. Meu Deus. A população tem que fazer isso, cara. Olha aí. Aí a mulher vai entrar agora. Olha aí.
Well, and that image, that hospital is called Abelardo Santos. And this hospital used to receive cases, different cases, like trauma cases, general surgeon cases, and pediatrician, OB. But when the pandemic starts to be uncontrolled, the government decides to become this hospital a COVID hospital. And population, when they heard this on TV, they ran to this hospital trying to get some help. And we saw things like that every single day. This is our field hospital with 400 beds. In the beginning, those beds were clinical beds, but the government decided to become them ICU beds. What's the problem with that? We didn't have doctors or nurses or people. We all were getting sick. Lots of our colleagues got sick. Much of them died. We had 34 deaths of colleagues, doctor colleagues. So it's a very high number. And when you compare with the number of doctors we have, 34, it's very much. And I think just one city have more deaths than us. I think it's Rio de Janeiro, but they have too much doctors more than us. So continuing that, after all this nightmare, we started a lockdown. This lockdown started in May 7th and was on Belem in more 5 cities. We have increased the cases and the deaths, and that was very horrifying for us. In the end of the lockdown, we had even more cases, but what happened? Those cases began to increase, but those were not ours from Belem, but in the other cities we have in the inside the state. So this image, this photography is from a lockdown day. It's a fair, a crowded fair, and it's full of people. And that's why we concern about, because population seems not to understand what was happening inside the hospitals. There was a policy from staying home and just get the hospitals when you get some symptoms and say which symptoms those were, but and sometimes part of our neighborhood doesn't understand what's going on, in fact. So this is very terrifying for us, seeing a crowded fair in the lockdown time. Okay, and nowadays what we have, seeing those numbers, we can see that our rate here in the north, our rate, death rate is very higher when we compare the other parts of the country. And those are our numbers actually. Yesterday, we had those confirmed cases, more than 6,000 cases, and more than deaths. Those numbers here are from our city. Those are the confirmed cases, and those are the numbers. This is from Belem only. When we compare the cases accumulated by the date of publication, we are the number 4. Just São Paulo comes first, and then Rio de Janeiro, Ceará, and then us in Belem. And this is our cases accumulated for the date. What was the problem with our numbers? First, we doctors, we used to think that there wasn't testing enough for the population because we have a death rate too big when we compare the number of cases we have. But sometimes we think that actually we don't test the number of cases that really are positive, because it's not, we are seeing the death people, but we imagine that we have too much more patients with COVID that the numbers don't show to us. That's why we can explain our death rate is being too high when we compare the others. And these are distribution of the number of cases we have. These in the red and pink, we have the cases confirmed. Here, this red one is our city, Belem. And we have some regions here with big hospitals that can receive patients. And maybe that's why they are a little bit more red than the others, because they receive more patients actually. Those are our accumulated cases. Even the confirmed cases in blue, the recuperated cases in green, and the others in red. Our death case is accumulated by the date of publication, and we still in 4th position in Brazil. And when we see the rates of number of cases in our city, in our cities, the capital Belem is the major one. And this is our curve. When we see the number of confirmed cases and death cases in red, we see that our worst part of the history was, in fact, the end of April and beginning of May. And then the numbers is starting to decrease. And that's maybe think about it. We think that, is that what is coming next then? Because our commercial is open already with some restriction, but they are already, the shopping centers are open already. And that's a point of concern to all. This is our ICU and clinical beds distribution. And we have a rate of occupation here. In blue, we have the clinical beds. See the more blue in Belem. And in green, we have the ICU beds. And we see here the higher number of beds in Belem too. So our reality is very different. One city sometimes doesn't even have one hospital, and the other cities sometimes have more than 5, 6. So it's very different between even inside the same state. So now we are talking about two different realities from the hospitals I work. First one, Barros Barreto, he's a federal state from the university. It is a closed door hospital, so we don't have ER. Before COVID pandemic, we used to have 10 ICU beds for our hospital. During pandemic, COVID pandemic, we turned more even beds to COVID. So we have 25 ICU beds, and from those, 20 are for COVID patients. We had to suspend elective surgeries, and plenty of surgeons become to work on ICU unity because we had too much colleagues which got sick with COVID. And we are now resuming oncological surgeries in the hospital. The next one is our trauma center. These trauma centers are open door, and we kept the open door for trauma during this period. And in fact, we are the only state trauma center that we have. And before COVID, we used to have 20 ICU beds for adults and 10 for children. Because of COVID, the hospital opened 20 ICU beds just for COVID. And we used to work this way. They opened a specific red room for COVID patients with a rapid response team. And this team were composed by the general surgeon of the shift. We used to intubate those patients and see and do whatever they needed, and then transferred to COVID unit inside the hospital. And besides all of this, we noticed that our trauma cases increased, maybe because of lockdown strategy, or maybe because we were the only hospital with open door for trauma. So when like all the other hospitals get crowded with COVID patients, so the trauma goes only for Metropolitan Hospital. So, seeing all that, we used to ask ourselves some questions, just like, where are we going? What we're going to do with that? And is there a second wave coming? Because we believe too much patients are not notified, in fact, but we don't know this. It's still a great question for us. But we have a current challenge happening. And these are the picture of our challenge. The Indians don't have immunity. And they are going to get sick, and they are already dying from COVID. And this is the point that we are which has our concern about. So I'd like to thank you and show you this river. My middle name comes from the name of this river. My great-grandfather was a river site of this river. So thank you all.
Thank you, Thais. That's why I want to have Thais presenting today. You can show the reality in the north of Brazil, the middle of the Amazon area. So that's a reality, multiple challenges, and a very hard situation over there. Let's go now straight to the last presenters. I would like to ask Dr. Kristin Miller, Dr. Marjolaine DeWitt from Virginia Commonwealth University to do their presentation. Then I'm going to go to the questions after that. Thank you very much for joining, Dr. Miller and Dr. DeWitt.
Thank you, Dr. Martos. I really appreciate the opportunity to present to your group. Everyone see my slides?
Yes.
Yes.
So I'm I'm the Associate Medical Director in the Medical Respiratory ICU here at VCUHealth. My background is in internal medicine, and I'm in the Division of Pulmonary and Critical Care Medicine. I also practice neurocritical care and work in our nurse science ICU. Dr. DeWitt will also be on after my presentation, and we'll be talking about some of the research and clinical trials with COVID-19 here at VCU. So at VCUHealth, we are in Richmond, Virginia. The population of Richmond is around 220,000. We are a tertiary care center and a level 1 trauma center. We are licensed for 776 beds here at VCU. 112 of those are ICU beds, but only 28 of those ICU are negative pressure isolation rooms. This is our hospital here in Richmond, and this is the critical care tower where our ICUs are. And in the medical ICU, we are on the 4th floor. This is a little bit about the COVID experience we've had here in Richmond. This graph starts on the 23rd of March and goes through towards the end of May. And this is the number of COVID positive admissions we've had by day. Only 1 to 2 for the most part, and then we actually started to get more in May with a peak here around 9. And this is the COVID positive admissions by day in the state of Virginia. So you can see kind of the overall graph and trend here. Towards early June, we were actually still going up in cases. This is the trend of the COVID-19 positive inpatients that we have here at VCU. The trend is still rising, although I actually am on service right now, and cautiously optimistic that things are starting to plateau here in Richmond. Our peak was around the 29th of May when we had 50 inpatients. A general rule of thumb that we've kind of seen here in Richmond is around 20 to 40% of our inpatients do require ICU care. So some of the things that we had to consider were surge considerations and how we were going to find enough ICU beds for patients, and the number and the location of some of our isolation rooms. Team capacity, as mentioned, has been challenging as well. All members of the team also trying to account for individuals that may get sick or affected by COVID-19. And those team members being ICU nurses, physicians, nurse practitioners, PAs, pharmacies, etc. We had multiple meetings. Dr. Abatanis was key into assisting us with coming up with a surge plan here at VCUHealth. And we're fortunate with his expertise and the group's expertise about mass casualty planning and trying to build a COVID ICU. One of the things that our group worked towards was 1 floor below us in the medical respiratory ICU is a general medicine floor, but they had multiple negative pressure rooms that could be used potentially. So we actually moved from going to an original plan of using our OR rooms for surge to these rooms. Unfortunately, they're not used for ICU, but we were able to stand that up in about a week's time to open more beds for our ICU patients, and we're fortunate that we were able to get that up and running. Obviously, another big consideration is just having enough supplies and masks for our staff and our personal protective equipment. This is just a picture of one of the ICU beds here at VCUHealth. We're fortunate that they have these glass doors that we can see inside. The beds here in the monitor. This is the supply cart here and a monitoring station outside. This is what our ICU looks like right now in the medical respiratory ICU. And this process that we've used was really honestly quickly circulated on social media about how to get the ventilator screen, and the infusion pumps outside of the room. And this has saved us an enormous amount of personal protective equipment, and we can still safely care for our patients. I was fortunate we saw this actually on the Facebook COVID provider page, that several hospitals shared their protocol with how they were able to achieve this. And you can see here is the ventilator screen outside of the room. And these are the infusion pumps, and the tubing that goes down. Actually used a stat lock device to help secure this tubing, and it goes underneath the door here to the patient, so using extension tubing there. So some of the things that I'd like to share with the group from our challenges in taking care of patients with COVID-19. As mentioned, this is a very, very difficult disease to treat. We've certainly lost patients to this. And honestly, I have never seen a virus like this in my training or career thus far. I remember taking care of patients with H1N1 and our ICU being more than 50% occupied with patients with H1N1 ARDS. And this, in my opinion, is much more severe. One of the challenges that we all face and greatly appreciate here in the perspective of other individuals is there's no randomized controlled trials. There's a lot of things that we're still learning about this virus. And one of the things that we've seen here at VCU is that supportive care is crucial to the care of patients with COVID-19. We have seen surges here at VCU, many of which are related to patients that came from local nursing homes where there were sporadic outbreaks. We also have a contract with the Department of Corrections. So we have had multiple outbreaks at men and women's prisons, and we've cared for patients that had COVID-19 as well. And one of the other things that's been obviously very tragic is that we've cared for many people and their family, and we've unfortunately lost some of those family members. So when we talk about the clinical challenges, along with all of the other challenges that we see, I wanted to focus on three things that I've noticed as we've cared for patients. One is just the critical care of respiratory failure and ARDS from COVID. The second one would be some of the coagulopathy issues we've seen. And the last would be endocrine and blood glucose control. So some of the questions that came to our mind is, what's the ideal mode of ventilation? Is COVID-19 traditional ARDS? What's the role of proning here, particularly given limited resources and the ability to use ECMO in some of these patients? When do you intubate patients with COVID-19? And are there other things to consider besides just pneumonia that's causing our patients to be so hypoxemic? So I'll start with the traditional ARDS question. We definitely had some cases that didn't quite seem like traditional ARDS, but I'll have to say from doing this for a couple of months now, and then also relying on some of the case reports and autopsy series, although small numbers of patients, we do have some autopsies in patients with COVID-19, and it has confirmed that we see the diffuse alveolar damage seen in patients with ARDS. So many of our patients require intubation, and as you all are well aware, this is a very aerosol producing procedure that places our healthcare workers at risk. At VCUHealth, we decided to lead the intubation to our anesthesia colleagues. And this is our anesthesia team here getting ready to intubate one of our COVID-19 patients. Here is our airway cart. We plan things out. We try to avoid bagging if we can, but we do have a filter on the end of the ambu bag if bagging is necessary. And this was the initial PPE that was worn by our anesthesia colleagues. You can see this is what's used in ortho surgeries here at VCUHealth, the gowns here, the N95 mask, and actually under this is actually a baseball cap and a clip device so the visibility is not affected. and the most senior person on the team would do the intubation. And our anesthesia team was great about also securing the tube, helping us set up the vent. So they added on a couple other responsibilities as well. Proning, you know, we talked a lot about this in the beginning about proning. Was it safe? Who should have it done? But I'll tell you, after several months of this, it's my opinion, and has been published in some other areas, that proning is very effective in COVID-19 ARDS. It's a mechanically ventilated patient that's proned. And we actually have been using that quite a bit here at VCU. It takes about 5 team members to prone an individual. We make sure that we have a physician and a respiratory therapist that are directly just responsible for securing the patient's airway during the process. Having the tubing outside the room, you know, an extra IV tubing did cause a little bit of difference in our practice, but our team did adapt to that and have gotten very good at proning patients. One story I'd like to share very quickly is we had a young woman who was very obese, but was requiring significant amount of FiO2 and PEEP, and she was about 400 pounds. Our team thought that they could do it, and we used 6 people, and were able to prone this patient, and the patient was prone for 16 hours a day, and the FiO2 requirement quickly went down with proning from 100% to 50%. And luckily, this patient was able to be extubated and survived, left the hospital. One thing new about COVID-19 is that there had been some prior studies, and honestly, I wasn't aware of them before this, but many places started talking about self-proning. And we are doing this quite a bit, as I imagine many of you all in your centers are as well. Just asking the patients to lay on their belly. Patients who tend to do best with this are patients who like to sleep on their stomach, that aren't so dyspneic that they can't do this, and usually need to be alert and able to converse with us. But self-proning has really helped, and we're working on trying to have a hospital protocol as well as a research study on this. What we have been using for our ventilation strategy is the ARDS-NET, assist control, volume control, and focusing on the higher PEEP and lower FiO2 strategy. Many of our patients do require deep sedation and paralysis, as well as proning. At our hospital, going back to the proning, we actually decided that it's much safer to do this during the daytime when we have more resources. So every day at 8 and 4 p.m. are our proning times. So we have used some of the rescue strategies as well. We have had a couple of patients that we used inhaled nitric oxide on. And honestly, we have not had any patients that have been approved for ECMO. We do have stricter guidelines, but we haven't, fortunately, had that many patients that we need to refer for this. Using other traditional strategies has been helpful. I'll just briefly talk about tracheostomies, given the risk of this. Most of our tracheostomies, we try to wait, at least 14 days, sometimes longer. If possible, if the patient would need to go to the operating room, we would re-swab that patient to see if they still had COVID. But our interventional pulmonary team has been doing some bedside tracheostomies on our patients with COVID. And many of them do require, just because another global thing that we've seen is these patients are just so ill and they are with us for weeks. I'll move on to coagulopathy. There's a clear increase in thrombotic events in patients with COVID-19. We've seen both arterial and venous thrombi. We've used some additional lab testing that others had also mentioned in their slide. D-dimer, fibrinogen, fibrin split products, and TEGs have been helpful. A small percentage of our patients do have also evidence of DIC. We are at our institution using higher doses of DVT prophylaxis because of this increased risk. But there's a lot of debate about that, as well as who should have empiric anticoagulation. We're focusing more on the empiric anticoagulation for patients who have prolonged mechanical ventilation or on CRRT or renal replacement therapies and continue to clot in the circuit. I wanted to share with you a few images of patients that we've cared for here at VCU. This patient has COVID pneumonia and ARDS. You can see the ground glass opacities and the patchy opacities here from the pneumonia. This patient was initially getting better with therapy, but then became more hypoxemic. So we did opt to have a CT scan to look for pulmonary emboli. And you can see here, this patient has multiple pulmonary emboli, even on the higher doses of the prophylactic anticoagulation. This is a patient that unfortunately died from COVID-19, and you can see the multiple thrombi in the aorta and the iliac artery here. Patient also had other thrombi as well throughout. This is a patient who has COVID ARDS. You can see the chest x-ray showing that bilateral ground glass opacities. This patient was very ill, intubated, sedated, paralyzed, and prone, had a known history of prior DVTs and PEs before admission. This patient was systemically anticoagulated due to that history and some of the serologic markers that supported coagulopathy. Unfortunately, this patient developed a spontaneous intracranial hemorrhage. So as you can see, coagulopathy is quite a challenge in our patients, and trying to decide how much anticoagulation has been also another challenge for our teams. Endocrine and diabetes, many of our patients, and as I'm sure yours as well, have underlying diabetes or hypertension. But what we've seen in some of our more severe cases is just a marked insulin resistance. I can think of a patient in particular that was on an insulin infusion at 15 units an hour and still had blood sugars in the 500s. We talked to our endocrine colleagues, and it has been reported, and it seems to be a very high insulin resistance. And then as the patient gets better, frequently that insulin resistance goes down. Obviously, there's a lot of challenges about insulin drips, and we have used arterial lines for glucose monitoring. We've also increased our NPH dosing to every 8 hours. We've also started to see medication shortages, equipment shortages, and a general COVID fear amongst staff, colleagues, and trying to get additional testing done. We've been trying to be very mindful of if a test is going to help us or not before we order that to expose other individuals. We're starting to have medication shortages on both propofol, which is one of our biggest medications that we use for sedation, as well as cisatracurium. Also, dexmedetomidine is likely going to go on shortages. We also have shortages of some of the devices we use for video laryngoscopes. And one of the things that's been particularly hard on patients, family, and staff is the visitation restrictions that were in place due to the pandemic. Normally in ICU, we have a non-restricted visitation policy. I'm going to stop there and send things to my colleague, Dr. DeWitt. He'll be talking a little bit more about our treatment strategies and research trials here at VCU.
Thank you very much, Dr. Miller. Can everyone hear me? Yes? Okay. Thank you for inviting us, and it's a pleasure to speak with you today about the COVID-19 experience here at VCU. Just to tell you a little bit about myself, I am a intensivist primarily. I'm trained in pulmonary and critical care medicine, and I obtained a master's in clinical research and outcomes research and in biostatistics. And so my research is really focused on clinical trials, even before the COVID-19 pandemic. Next slide, please. So when the COVID pandemic reached Richmond, we already obviously had warnings from many parts of the world, China, Italy, the remainder of Western Europe, the west coast of the US, and then finally it came to us. And this gave us an opportunity to prepare the research environment for COVID. One of the very first things that happened is the president of the university established or told the dean of research, Dr. Joao, to establish a COVID clinical trial research committee. And the goal of that committee was to prioritize study. And in prioritizing studies, one of the things that happened is that non-COVID research was very much halted or brought to a major slowdown. Only studies that could not be stopped because of the COVID pandemic were permitted to continue. The other thing the COVID Clinical Trial Research Committee did, and I'm a member of that, is we decided to prioritize the studies. And the priority was really based on pre-existing data, mechanism of actions, and what offered patients the greatest chance of benefit. Obviously, at this point in the pandemic, having new medications is really not an option. Medication development takes years. And so it was mostly new applications of old molecules. The first one that jumped on the list was really remdesivir. This was the Gilead-sponsored remdesivir trial, SIMPLE. And a hepatologist at the institution is very well connected, and he was able to get us involved in the Gilead remdesivir trial, the SIMPLE trial that was published a couple of weeks ago. More data is forthcoming. The other study we decided to embark upon is an anti-IL-6 receptor sarilumab. And the reason for this was because of the tocilizumab data suggesting that there might be a benefit. And the theory is that these medications would address a cytokine storm. Finally, I'm also part of an NIH network called the PEDAL network. PEDAL stands for Prevention and Early Treatment of Acute Lung Injury. And it's basically a group of ICU docs and emergency medicine docs who basically we are trying to prevent or treat ARDS early. And the PEDAL network, in a span of 13 days, was able to develop a hydroxychloroquine versus placebo trial from implementation to approval. The PEDAL network is 50 hospitals across the US. And so right away, a large network was available to start this study. And that trial is going to enroll 510 patients. We're just above 420 patients at this point, and we started a month ago. And then finally, canakinumab is an anti-IL-1 monoclonal antibody, is also being tried. There's many other studies, but these are really, at this point, the bigger trials going on. Next slide, please. So one of the things the committee did is we basically mapped out the spectrum of disease of COVID. And it ranges, as you can see on the left, to someone who is out of hospital and does not need hospital admission, to progressing further to the right, people who need to be hospitalized, have a pneumonia, require supplemental oxygen, to people who end up developing in the ICU, having ARDS, needing mechanical ventilation, and developing multi-organ failure. And so what we did is we mapped each and every one of these medications as to which patient population would this target. And based on the potential of benefit and the spectrum of disease, we graded studies with a scoring system, and the higher the score of, or the better the score of a study, that study was allowed to talk to a particular patient in those various study groups first, and then it went sequentially down the line of to other studies that got lower ratings. Next slide, please. So how did we operationalize this? Well, I ended up being on most of these studies, especially early on. And basically, the research was linked very closely to collaboration with the medical teams, mostly internists. There was also a couple of patients on trauma surgery who had COVID-19. But it's basically, we were there to try to help the research, the medical teams, the clinical teams, if they wanted help in offering a medication to their patient. And so these daily rounds were really held remotely via Zoom. And basically, remdesivir is the study that got the highest score, and we enrolled over 70 patients in the SIMPLE trial. And that was the first study we would talk about in the morning. After we, actually, I would pre-round on all the remdesivir patients, present them at 7:30, and then we went sequentially later times to different studies. Sarilumab, now we're doing canakinumab. There's an ORCID group as well. Next slide, please. So how do you get consent from patients or families who you cannot speak to in person? If you had ever told me that I would be getting remote consent 6 months ago, I would have asked you, under what circumstance is this possible? But this is what's happening. We call the patients or the legally authorized representative or family, and we speak to them. Initially, for the remdesivir trial, all we had was a paper consent because it was so early on. And that piece of paper would go into the patient's room the next time the nurse entered the room, and the patient would sign the consent, and we would take the consent out of the room, put it in a biohazard bag, and then it was exposed to UV light in a chamber. Now we're really doing everything remote consent. We send either a copy of the consent by email, and patients sign off on it, or now in the ORCID, the NIH Pedal Network ORCID trial, we're actually using REDCap, and the patients basically just click, and that click is their electronic signature. Next slide, please. So to date, you can see these are all the studies we've had. The remdesivir trial are the first two, and we've enrolled over 70 patients in that. The sarilumab anti-IL-6 receptor monoclonal antibody, we have 10 patients, and canakinumab has 20 patients. ORCID, that's the hydroxychloroquine, has really had a very interesting evolution over the past 10 weeks. Initially, when remdesivir started, the remdesivir study started, the argument was that it was unethical to offer hydroxychloroquine because of the 2 small studies coming from China. And then data about concerns with hydroxychloroquine emerged, and it was that ORCID really should not even be done because it's unethical to give hydroxychloroquine. And now we're more again in a situation where hydroxychloroquine might offer or might not be as harmful as people suggest. So it's in a seen in a less favorable light. Now, one of the things, next slide, please, I do want to point out is that none of these agents are FDA approved for the use of COVID-19. This is one of the disclaimers I want to make very clear. These are all being investigated currently. And in fact, some agents are not at all FDA approved for any indication. And that's pretty much all I have from a research perspective. Thank you very much. Thank you very much.
Okay, thank you very much. Great presentation, great update, and a huge contrast from the previous presentation. So we are ahead of time, so I would like to ask the panelists to do brief comments and briefly answer the questions. So we can have a presentation from Dr. Napoleon honoring Dr. Basilio. So, Doctor, the first question to Dr. Ricardo Lima. Ricardo Lima, so in your unit, what kind of device can you give to our friends in Pará, Brazil, to help treat the patients in not ideal situation like they have over there.
Thank you for the opportunity, Marcus. You asked about the device for what in my unit? You comparing to Pará, what? I do not understand.
No, what kind of advice can you give? Advice, conselho can you give to them when you don't have all the expertise, the physicians, or even equipment available to treat it?
I suppose that I don't have. Thank you for your explanation. When you don't have all the devices, you have to put the people around next to the patient. I suppose the main care they have to say that stay besides the patient to see the evolution, because they evolve very fast for respiratory damage, and they have to stay around. They should prone the patient and should try to ventilate with the best PEEP. And of course, if you don't have the idea is to use some non-invasive ventilation and sometimes of nitric oxide. But if you don't have that, you have to try to ventilate the patient as much as need, and to stay beside, to try to discover the best PEEP and to prone when it's necessary. But the idea is to be near the patient most time, because it's changed very fast, and becomes, like you used to say, a patient who goes to the multiple organ failure, and it's very difficult to do that. Thank you.
Thank you very much. That's a question from Dr. Neira from Enrique Ginsburg. So his question, Dr. Neira, is about the Argentina national data regarding mortality rates, and saying that this data shows the mortality rates close to influenza. What is your opinion? Is it to the mutation of the virus, or to treatment modality? And if your Fundación Trauma helped to do that, please let
Thank you, Antonio. Thank you, Antonio. Thanks to Enrique. The data, Enrique asked you, the data is accurate in Argentina. We have a database collection in the National Ministry of Health. There is a situation room with the data collection, and the data is real. The data is like I show you. And the mortality perhaps is related that the groups in risk are related to the poor settlements, and the poor settlement has no older population. And then there is a lot of people with moderate and mild disease. I think this is the reason by the mortality. It's the same that in Uruguay, in Argentina, I don't know exactly in Venezuela, but the lower mortality in Latin America is in Colombia, us, Uruguay, Paraguay, and Venezuela. I don't know if it's a mutation of the virus, but perhaps it's related to the risk population.
Thank you very much, Dr. Neira. A question from Dr. Gabriel, from Dr. Ana Gabriela Figueiredo to Dr. Thais, regarding social distance and isolation. You saw that the numbers of cases, the curves in Pará, didn't follow like the pattern for social isolation. So do you think that this really happened, or the problem that you had was because the social distance, or didn't happen at all, or how can you answer that, Dr. Thais?
Well, our social isolation rates always were lowest than they intend to be. So the isolation rate was always better when in the richest part of the city, but the parts with more poverty, they were just unbelievable. So yes, I think the isolation doesn't happen in our city, and that was one of the reasons that increased the numbers of cases and deaths here.
Thank you very much. I have a question from Dr. Luis Herrera from Peru, saying that in the high altitude, they're seeing decreased rates of contagions of COVID-19. And then Dr. Ginsburg answered to that, and saying about UV light, because you use here in the hostels UV light to try to sterilize our rooms or some device. So Dr. Swanini, do you have the same feeling that at high altitude of Bolivia, I'm going to ask the same question for Dr. Felipe Vega, the high altitude in Mexico, do you think this has any influence on COVID-19?
Yeah, I was just answering that right now. I was typing it in. I'm going to send a link to the only article that I'm aware of that talks about this. They compared Tibet with Bolivia and Ecuador. I can speak about the experience in Bolivia. There's been less cases of COVID in the Andean region. There's been more cases in Santa Cruz, which is Amazon, and also in Beni, which is also Amazon. But what I'm starting to see is that the cases are increasing at altitude. And my general feeling is I don't think that altitude necessarily protects against this or UV lights, but that is a theory. I think that's more that the populations tend to be very isolated, not so densely populated. Now, La Paz is a very densely populated city, but I think that they're behind the curve in relationship to the Amazon region. And unfortunately, I think they're going to have an increase of cases over the next couple of weeks. Hopefully I'm wrong, but that's my impression.
Thank you very much. The last question going to be regarding the data from VCU. So there will be Dr. Barreto to Dr. Sandro Rizzoli. Both of you, what kind of research have been doing? So what's working, what really worked and what didn't work in the treatment of these patients, the critical patients in intensive care unit? Dr. Barreto and then Dr. Rizzoli, please.
Dr. Barreto is not here, Doctor.
Well, Dr. Barreto disconnected. So Dr. Rizzoli, so what do you think about research? What works, what didn't work? Your comments regarding the presentation from VCU, please.
I really enjoyed the presentations today. I liked very much, particularly the comments on Dr. Miller and Dr. DeWitt. I will just extend that. I believe that there is no proven therapy. The best management for COVID today is a doctor, is a nurse, is an RD, is an ICU support. That's the best, the proved treatment. There's no proven drug, there's no proven anything that will make a difference like an ICU. And I believe that a lot of the casualties of this pandemic happened because too many people got sick and we didn't have enough ICU professionals to take care of them. So we're seeing nurses from psychiatric unit now working in an ICU caring for COVID patients. And the outcome is not the same. So we all doing an effort. This is hitting the whole world. And a lot of patients could have a different outcome if these were different times, but they were not. We were not prepared for this pandemic. Most governments in the world didn't do a good job getting us ready for that. So research is behind too. Again, I was so pleased to see the list of research in there. And let me pull a little bit the sardine to my fire. So the Panamerican Journal of Trauma has created a new section that we call Perspectives. If you have a short paper on COVID-19, consider submitting it to the Panamerican Journal of Trauma. All the COVID-19 papers have been fast-tracked. We're going from submission to publication in about 2 weeks. So go to the Pan-American Journal of Trauma, read our online articles, and consider submitting your work to the journal. Thank you very much.
Thank you, Dr. Rizzoli. Just emphasizing what you said, the publications from the Panamerican Journal of Trauma, Critical Care, and Emergency Surgery. So critical care topics are welcome also to the journal. Thank you very much. I would like to go now to the most important part of today's webinar. Unfortunately, we lost one of our most active members, distinguished professor, a friend, this week, Dr. Alberto Basílio. So I would like to ask Dr. Esteban Fognini to introduce Dr. Napoleon Mendes. They're gonna say some words about Dr. Basílio. Esteban, please.
Thank you, Dr. Martos. Actually, the loss of Alberto has hit the entire community of surgeons in Latin America and members of the Pan-American Trauma Society. And it's been a very difficult time for us because of this. Dr. Mendes is a distinguished professor of surgery and a very close friend of Alberto. They shared during the meetings, but Alberto would visit him regularly and help him develop different trauma courses and also develop the FAST team. So I don't want to take any more time. Dr. Mendez, if you please start your presentation. Thank you.
Gracias a todos por este espacio, por esta oportunidad de dirigirnos a todos de la Sociedad Panamericana de Trauma en un momento tan difícil. El mundo entero está sufriendo mucho las consecuencias de esta terrible pandemia y todas las charlas giran alrededor de las consecuencias, pero hoy nos ha tocado sufrir de cerca el dolor de la ausencia que nos deja este amigo.
So Dr. Mendez says, thank you for giving me the opportunity to speak at this time, which is so difficult in the world. And it has been made more difficult by the loss of a great friend.
Un segundo que tengo un problema aquí en la presentación. Ok. Sí, ¿se observa el video, Esteban?
Sí, sí, perfecto, gracias.
Muy bien. Este es el Distrito Federal, la Ciudad de México, que hace 58 años vio nacer a nuestro amigo Alberto Basilio Olivares. Voy a compartir unos pocos minutos de un video que fue editado por el Discovery Science, donde tiene que ver mucho nuestro amigo Alberto y resume gran parte de la vida académica con muchos de nosotros. Este reportaje lo hicieron hace unos años en el Discovery. Si puedes traducir, Esteban, perdón.
Claro. So he originally showed an image of Mexico City, which showed a place where Dr. Basilio was born 58 years ago. And this is a video from a program from Discovery Science, which was done a couple of years ago, which shows Dr. Alberto Basilio and practicing trauma surgery in that city. No tenemos audio para este video, yo lo he visto en parte previamente.
¿No escuchas el audio?
No, no se escucha, pero está bien.
Ok. Bueno, están haciendo la descripción en ese momento sobre el Distrito Federal, la cantidad de habitantes que tiene el distrito, más de 20 millones, una ciudad bastante violenta, con mucha experiencia en trauma. Y están haciendo la descripción de la Cruz Roja Polanco, donde Alberto Basilio trabajó muchos años.
So making a description of the city of Mexico City with 20 million population and with a high level of trauma. And there we can see Alberto. And they're describing the hospital where he used to work, which is Cruz Roja Polanco. Sí, Napoleón.
Sí, están describiendo en el video sobre el qué hacer de la Cruz Roja Polanco, uno de los centros de trauma más importante del Distrito Federal, y el doctor Alberto Basilio, uno de sus exponentes más importantes.
So just describing, you know, this is one of the major trauma centers within the city of Mexico, and Dr. Alberto Basilio was one of the main principal personnel or physicians within that unit.
Bueno, podríamos resumir que gran parte del qué hacer de la vida de Alberto fue precisamente su dedicación a la carrera de medicina y específicamente un apasionado del trauma.
So we can say that he was a very dedicated physician and he was very passionate about trauma.
Sus características se resumen en básicamente un hombre de bien, un científico, un artista del bisturí, un apasionado médico clínico, un hombre de pocas palabras y de muchas acciones, respetuoso de la ciencia y de los maestros.
So if we were to go ahead and just briefly summarize, he was a good man. A scientist and an artist with a scalpel, passionate about clinical medicine, a man of few words and many actions, and very respectful of the science and the professors.
Fue siempre un alumno eterno, una persona de fuerte carácter, pero con algunas debilidades. Podría resaltar algunas de ellas, que era muy perfeccionista y se condenaba mucho cuando fallaba por alguna acción. No le gustaba fallar. Era un hombre muy creativo, en constante crecimiento. Alberto siempre estaba creando y siempre tenía nuevos planes y sus metas académicas eran cada vez más ambiciosas.
So he was a constant student, a man of very strong character. He had some weaknesses. He was a perfectionist. He was very critical of himself when he failed. And he suffered deeply because of his search for perfection. He was a creative man who constantly looked to grow or become better. He had always new plans, and his academic goals were always more ambitious.
Tuve el gusto de conocer a Alberto en Caracas, Venezuela, en junio del 2007, durante un congreso suramericano de trauma choque. Tengo una anécdota muy particular. Cuando conocí a Alberto, ambos estábamos en la espera de registrarnos en el hotel y él siempre contaba y hacía bromas sobre cómo nos encontramos. Yo me dirigí a Alberto y él siempre lo contaba y decía: cuando conocí a Napo pensé que iba a asaltarme porque iba con un pantalón de nona roto, rapado, con aspecto de pandillero, y me preguntó si conocía a Pedro Serpa, y yo lo que hice fue entregarle la billetera. Así bromeaba Alberto cuando se refería a nuestro primer encuentro.
So I met Alberto in Caracas, Venezuela in 2007 during a trauma meeting. And I met him while we were registering the hotel. And he always used to make the joke that when we met each other, that he thought that Dr. Napoleon was gonna rob him, that he looked like a gang member because he had torn jeans and he had a shaved head. And he had asked Dr. Mendez, "Did you know Pedro Sarpa?" And immediately gave him his wallet. They shared more than 10 meetings together, and was enough to be able to say, to appreciate his passion and his style of life. He was always joking and jovial.
Durante ese evento compartimos con Alberto más de 10 conferencias, las alternábamos. Él daba control de daño, su servidor trauma cardíaco, el trauma torácico y otro trauma de abdomen. Y fue suficiente para conocer de ambos el particular estilo de vida y la pasión por el trauma.
So during that meeting, they actually shared 10 conferences, and they would alternate between damage control or laparotomies, and that highlighted their passion for trauma and for teaching.
Eso es uno de los eventos múltiples en los cuales compartimos con Alberto. Fue en Puebla, México, en un Panamericano de trauma.
It's one of the multiple meetings that we shared together. This is in Puebla, Mexico, the Panamerican Trauma Society meeting.
A partir de esta amistad nació una productiva relación académica muy particular en ambos países, creciendo no solo en el número de amigos, sino que en el número de congresos compartidos, el número de cursos y cada vez más proyectos en conjunto que hermandó no solo a Alberto y a mí, sino que a muchos de los amigos, incluyendo muchos de los que están acá en la Sociedad Panamericana. Y a pesar de la cercanía y amistad, siempre lo vi como un hermano mayor y un gran maestro.
So out of this friendship, there was a very productive academic relationship between both countries, and this allowed other friends and colleagues to share experiences and during meetings. And despite the fact that our age was close, Dr. Mendez's feeling is that Alberto was like an older brother and a great mentor and professor.
Tuvimos entonces compartiendo algunos eventos tanto dentro de Guatemala como fuera de las fronteras. Aquí podemos ver algunas de las reconocidas figuras de la Sociedad Panamericana de Trauma. Pueden reconocer a Juan Carlos Puyana, a Carlos Morales, al doctor Ricardo Ferrada y al doctor Darío Virolini, entre otros, y por supuesto Alberto no podía faltar entre los participantes.
So you can see here at a meeting in Guatemala, Juan Carlos Puyana, Ricardo Ferrada, Darío Virulini, and Carlos Morales, amongst other prominent members of the Pan-American Society.
No le conocí vicios a Alberto, pero tenía una afición bastante particular por el café de Guatemala. Era adicto al café de Guatemala, y tanto así que mi requisito para poder entrar a los congresos en México era que tenía que llevar una dotación de cafés, por lo menos 10 libras tenía como requisito para poder entrar al país. Y gracias a eso siempre me detenían en el aeropuerto, gracias a esos paquetes sospechosos.
So I did not know any of Dr. Basilio's vices, but he did have a great liking for Guatemalan coffee. And it was always a requirement that if I had to go to Mexico for a meeting, I had to bring his share of coffee. And I was always stopped at customs because I was carrying these suspicious packages from Guatemala to Mexico.
Su círculo de amistades, tanto en Guatemala como en la Sociedad Panamericana de Trauma, fue innumerable. Se ganó el respeto y la admiración de todos.
So he had a very wide circle of friends, not only in Guatemala, but also through the Pan-American Trauma Society. And everywhere he went, he garnered the respect and the admiration of the people.
Tuvimos visitas constantes y pudimos compartir incluso cirugías tanto en México como en Guatemala. Ahí estoy conociendo el lugar donde él se desarrolló durante mucho tiempo, la Cruz Roja Polanco.
So we shared many experiences throughout the years, and this is a visit I did to Cruz Roja Polanco in 2009.
Él mostraba con mucho orgullo los logros de la Cruz Roja, de los cuales él era artífice, y de todos los instrumentales y todas las mejoras por las que él realmente vivía para el trauma.
So he was very proud about all of his accomplishments and all the things that he had done to improve the quality of trauma care in this facility.
Aparte tenía una gran cultura culinaria, y los que fuimos sus amigos pudimos conocer muchos rincones especiales de la rica comida mexicana.
So he was a culinary expert, and for those of us who were close friends, he took us to some marvelous restaurants within Mexico to enjoy the very good Mexican food.
Compartimos muchos eventos nacionales e internacionales y varios panamericanos, y por ser su amigo, no me perdonaba que no lo escuchara y siempre me exigía que lo criticara y me fijara cómo presentaba para poder mejorar siempre.
So we shared many meetings together in Mexico, Guatemala, and throughout the Panamerican Trauma Society. And he would never forgive me if I did not listen to him giving a presentation. And he required that I be critical of his presentation so that he could improve on that.
Muchos pudimos tener el gusto de conocer a Alberto de cerca y ser sus amigos durante muchos eventos de la Sociedad Panamericana de Trauma. Pudimos escuchar la maestría y el dominio y la experiencia que él tenía en la cirugía de trauma.
So many of us got to share with him throughout different meetings, and we could actually enjoy not only his expertise, but his mastery of trauma surgery.
Se afanaba mucho porque los latinos tuviéramos un lugar especial en el mundo del trauma y decía que los cirujanos de trauma latinos éramos como unos guerreros.
So he always made a point that to highlight the accomplishments of Latin American trauma surgeons, and he felt that the Latin American trauma surgeons were true warriors.
Eso fue otro evento en Asunción en el 2011 y una de las múltiples presentaciones brillantes de Alberto.
So this is a different meeting in Asunción, Paraguay, and another one of his brilliant conferences.
Este es uno de los últimos eventos. Era muy importante. Estábamos en un cónclave en la provincia, en Guatemala, y para Alberto era tan importante un congreso mundial como un congreso local de estudiantes. Y se esforzaba al máximo para dar lo mejor, no importando la relevancia de los congresos. Todos eran importantes para él.
So to highlight one of his qualities was that he saw every meeting as being extremely important. Didn't matter if it was a large scientific meeting or a meeting with students. He would always give his best to make sure that there were quality presentations.
Podríamos hablar de que hay un antes y un después de Alberto Basilio en Guatemala. Él marcó el inicio del FAST en el país centroamericano, que ahora es tan cotidiano. Él fue el primero que impartió el curso, fue uno de los primeros alumnos de uno de los impulsadores del FAST en América, nuestro maestro Aurelio Rodríguez, y fue uno de sus más disciplinados y dedicados alumnos.
So we can say that there's a before and after with Alberto. He brought the first FAST to Central America, teaching at Guatemala, and this was after being trained by Dr. Aurelio Rodriguez. And Dr. Basilio was one of the most dedicated and prolific students that Dr. Rodriguez had.
Este es uno de los múltiples cursos de FAST. En el último año instruyó más de 100 personas entre pediatras, cirujanos y emergenciólogos.
So this is one of the FAST in 2016. He trained over 100 physicians, including pediatricians and surgeons.
Esto es en tu país, Esteban, en el Congreso en Bolivia.
There's an image from the Congress or the meeting in Bolivia.
Esto fue en el 2015, durante otro de los múltiples eventos en Guatemala. También compartíamos un diplomado de trauma, del cual era el creador y el profesor en la Universidad Autónoma de México. Eso fue en el 2016.
So there's a different meeting in Guatemala 2016 as they were teaching a diplomat in trauma from the University of Mexico.
Esto fue uno de los últimos congresos que compartimos en la provincia. Pasamos a tomar indispensable para Café con Alberto y siempre planificando planes para futuro, más cursos, más congreso, más aprendizaje, más enseñanza. Era incansable académico.
This is one of the last times that we were together in 2018, stopping for the prerequisite coffee. And Alberto was always tireless and dedicated in teaching and participating in meetings.
Este es el último FAS reciente que Alberto nos impartió el 18 de diciembre del año pasado.
This is the last FAST course that Alberto taught on December 18th, 2019.
Su trayectoria es muy amplia, pero para resaltar los puntos más importantes, fue vicepresidente de nuestra Sociedad Panamericana de Trauma, presidente de la Sociedad Mexicana de Trauma y socio fundador, miembro honorario de varias sociedades y universidades, editor de la revista Trauma en Latinoamérica, autor de múltiples capítulos en libros y revistas científicas, un conferencista connotado y un fundador e instructor asiduo de muchos cursos de trauma.
So Alberto's trajectory is extensive. He was a past vice president of the Panamerican Trauma Society, president of the Mexican Trauma Society, and also it's one of the founders, honorary member of multiple societies and universities, editor of the Trauma Journal for Latin America, author of multiple chapters in textbooks and also scientific publications, very well respected speaker, and he started or initiated several courses and actively participated as an instructor.
Uno de los últimos galardones que tuvimos el gusto de darle a Alberto, en el cual la Escuela de Estudios de Posgrado de la Universidad de San Carlos de Guatemala lo dio el título de profesor honorario.
So this is one of the last merits that we bestowed upon Alberto Basilio as honorary professor of the university in Guatemala.
Ha sido sumamente difícil el poder expresar con suficiencia tantas cosas que hay detrás de este gran científico, de este gran hombre, de este gran compañero, Alberto Basilio. De verdad que ha sido difícil para mí expresarme ante ustedes por estas negativas emociones por su partida. Como muchos, el COVID se lo llevó no sin dar una gran batalla. Hasta pronto.
So it's been very difficult to talk about this great friend, this great surgeon, this great partner, and who has succumbed to COVID, not without giving a very strong battle. And he appreciates, Dr. Mendez appreciates the opportunity to speak at this very difficult time for him.
Hasta pronto, Alberto. Nosotros en uno de los múltiples cursos que era instructor en de destrezas quirúrgicas de trauma, le decíamos íntimamente Hulk. Hasta pronto, Hulk.
So, farewell, dear friend. Amongst the intimacy and as a friendship, we used to call him Hulk. So, farewell, Hulk. Muchas gracias por tu palabra, Napoleón. Sé que ha sido muy duro. Amigo muy cercano para vos, un amigo para todos nosotros, pero claramente tu relación era una relación muy especial. Sé lo difícil que ha sido y te agradezco compartir con todos nosotros.
I'd like to ask all the members of the Panamerican Society, everybody in this webinar, in the honor of the memory and to honor the legacy of Dr. Basilio, to make a minute of silence, please. We start this conference to try to help people, to help our friends, to help ourselves to understand this disease, and to try to learn with each other and to collaborate in a way that you could face this the best way possible. I think you all know somebody that died or had problems. I had friends in Brazil, I had friends in the hospital that had issues, some survived, some died. This epidemic, this COVID-19 gonna leave scars forever in all of us. And I truly hope that as human beings, we're gonna improve, we're gonna live better and appreciate the things that we have. I cannot wait to be able to see everybody in a conference and give hugs, because that's what this is about. I'd like to ask Dr. Felipe Vega, the President of the Panamerican Society, to finish this webinar with some words to all the people in Latin America and the world to move on. Dr. Felipe Vega, please.
The only thing that I want to talk is to all the health personnel have to be safe, to take care of yourself, because the days are in, Latin America is in crisis right now, so we have to be safe and try to deal with this with a better manner, protecting ourselves. Thank you very much.
This is not over. That's why we're continuing doing these webinars. We still need support in Latin America. This is Panamerican Society. We're still doing this, try to collaborate as much as we can. And I hope soon we can finish these webinars. And what is our mission to stay doing this for a couple more weeks. Everybody stay safe, stay strong. Thanks, Valeria, Gary, Gladys. And I hope to see you all next week. Thank you very much.
Bye-bye.
Thank you, Antonio.
Thank you very much for all.
Bye-bye.